I've already introduced myself. You all know me. If you have questions or comments, my email is at the bottom. My task was to review oral medications and particularly gaps and developments that have been very, very recent in potentially new treatments that are orally active. So when we think about the issue of oral treatments, there is one category of medications which I refer to as special medications for special circumstances. The two best examples, I believe, are probably dopa-responsive dystonia and Wilson's disease. You all know these. I'm not going to review them. This review actually describes about 30 other disorders that have special treatments. They can be very, very effective, although they are not particularly useful for the broadest category of patients with dystonia. That is the patients with adult onset focal dystonia or many of the primary dystonias or isolated dystonias. So that much larger group of individuals, when it comes to oral medications, we have a ton of them. But the reason we have so many is because none of them really is particularly effective. We all know about using anticholinergics, and some of the examples are listed here. Dopaminergics can sometimes be used, and they're listed here. GABA-related drugs, muscle relaxers, and a whole host of miscellaneous drugs that are sometimes offered. The reason that there's so many of these is there's no real one winner, I guess, in this group of adult onset focal dystonia subjects for treatment, and they all have side effects, which we all know about, and I'm not going to go into the details. So there's quite a gap in oral medications for the dystonias that we need to address. Sarah, a couple of years ago, looked in the community to figure out, well, which of these various medications are being used by the majority of patients. It was a Dystonia Coalition database study that involved multiple centers in America, Europe, and Australia. There were over 2,000 cases included here, all types of dystonia, but most of them were, as I mentioned before, adult onset focal dystonias because those are the most common. You can see the results over here. The light blue bar means this is the percentage of participants actually taking the medication. The first one is the botulinum toxins, as Cindy just talked about. You can see about 60% were on them. And then you can see the others here. Benzodiazepines were used by about 30%. And then all of the rest of these were used by less than 10% of people. And I think that's a testament for the fact that they don't really work all that great, or we would be using them more. So how do we get to new and better things? Well, there are many different ways to do that. I want to mention briefly a couple examples. There's been a lot of interest in glutamate receptors because they are widely distributed in regions of the brain that are thought to play a role in dystonia. There are numerous animal studies that have implicated glutamate receptors. One gene in particular has been linked with human dystonia. And ages ago, there was a small study of riluzole, which is a weak antagonist of glutamate receptors, which implied it could be useful for patients with cervical dystonia. So this then led to a study that was organized by Susan Fox. She and Cindy Comella, they took a look at Perampanel, which is an AMPA glutamate receptor non-competitive antagonist. And the results that were encouraging a trial of this drug were coming from animal studies with several models showing some benefit. The fact that Perampanel was already in use as an anticonvulsant made it easier to test. So there was a very recent trial published just last year, phase 2A exploratory, multi-center, open label. 25 subjects with CD were recruited at the end of the botulinum toxin treatment cycle when symptoms were most prominent. There was a titration phase, and the main assessments were tolerability with some assessments with rating scales to see if there was any improvement. Many of you have probably seen this study already, so I won't go into it in detail. Let me just say that there might have been a hint that it could work, but the tolerability was not nearly as good as we had hoped. So if we're going to be using a drug like this, we might need to figure out lower doses, or perhaps a medication that might be better tolerated in the population that we need to use it. And there were many reasons for poor tolerability. I won't go into the details. One of the things that I wanted to emphasize is this is one of the first studies that we've done in the era when many subjects are already on botulinum toxins. So we learned an enormous amount about how to do an add-on trial with an oral agent when patients are already receiving a botulinum toxin. And that will help us going forward testing this or related drugs or even other drugs. Let me go on next to another glutamate antagonist, Dipraglurant. Hard to say. This is a negative allosteric modulator of the mGluR5 receptors, and preclinical studies implied that it might be useful, and it reduced levodopa-induced dyskinesias, including dystonic dyskinesias in both animal models and in Parkinson's disease. So this became an attractive target to have a look at as well. And a study was organized by the folks at ADEX. This was a phase 2A exploratory double-blinded trial with the randomization to placebo, 50 or 100 milligrams. 15 subjects were recruited. We looked at safety and tolerability, clinical rating scales, but also some digital rating scales and a wearable sensor that you'll hear about a little bit later when Dave gives his presentation. Recruitment closed just last month, and we were hoping to have some results for you to describe how this has gone, but they are not yet available, and we think they'll be available in a month or so. So another study, which again was a study in many patients already getting botulinum toxin, and a good design for an add-on trial to see if we can detect an effect with a promising new drug. So how do we find these new options? I gave you two examples. We can adapt existing medications already in use that might have some hint that they work in dystonia, but we want to make them better. For example, muscarinic selective anticholinergics might be useful. We can learn from other disorders where there are dystonic features, and we have done that for Parkinson's disease and Huntington's disease. Certain drugs in those populations seem to be good for dystonic dyskinesias, and they become interesting targets for us to try in pure dystonia disorders. Then there's been a lot of work in animals, sometimes empirical work, sometimes based on pathogenesis. And so if you want to look at the many options that are being considered, you can look at these articles here for some examples. And if you look in these articles, you'll see a whole host of things that could potentially be tested with various levels of evidence that make them interesting targets. Okay, I wanted to focus very briefly on one of the examples that has really heated up in the past couple of years, really. That is a mechanism-based identification of new medications. And here, the example is neurodegeneration with brain iron accumulation. This is a very rare disorder. It's not one of our adult onset focal dystonias, but it's a great example where understanding mechanism can really lead to interventions that may be useful. You probably all know about this disorder already. It's autosomal recessive, caused by this gene, and the enzyme is shown here. The consequence is impaired coenzyme A synthesis and iron accumulation, which gives you an MRI that looks like this over here. We call it the eye of the tiger sign. You probably also know that there are classical and atypical forms. Dystonia is very common in all the forms, and it's often the most severe of the features that we have to deal with. So the reason this has become such a hot topic and hot target for treatments is because the pathway for this disorder has been very clearly worked out. The gene is up here, and it's involved in this pathway for coenzyme A synthesis. I'm not going to go into the details of this pathway at the moment, but there are articles I'll refer you to later. We know that when this gene is missing and there's deficiency of this enzyme product, you lead to presumably reduced coenzyme A, and for reasons we don't really understand, there's iron accumulation. Now, understanding this pathway has been very helpful because 3 different targets have already been tried in this disorder to see if they would help. These 3 medications did not have a positive effect, presumably because their penetration across the blood-brain barrier wasn't as good as we might like. But there have been more recent ones, for example, targeting the accumulation of iron with the drug that's been available for other disorders. This was published just about 2 years ago. It was 89 patients, randomized, double-blind, placebo-controlled, with 18 months duration, and the endpoints were the Barry-Albright Dystonia Rating Scale and the Patient Global Impression score. And of course, there was a measurement of brain iron to see if the drug actually got in, it worked. And I'm going to review very, very briefly, just as an example. Here's a placebo-treated patient on the top. You see the eye of the tiger sign. These are iron-related sequences at baseline and at 18 months. And you can see there's not much change over the time period. Here's a patient who was treated with Deferiprone. You can see the baseline. You can see marked reduction in brain iron. And the entire group is shown over here in the blue line. So placebo shows no change over the 18 months. Blue line shows marked reduction in the iron signal. So the drug got in, it did what it was supposed to do. The problem is it didn't change the clinical rating scales or the patient rating scales. And the reasons for this are not entirely clear. It's possible that this damage that's created by iron is not reversible, but it's also possible that 18 months duration is just not long enough for a disorder that's already been going on for many years. So this is very promising, and I think you're going to hear more about this in the future. In addition to Deferiprone, I have a question mark here because we're not sure it's clinically effective, even though it seems to be effective in biomarker studies. There are 2 more studies on the way. The coenzyme A or CoAZ study has recently, I believe, completed recruitment, and results are supposed to be analyzed and available very soon. And then there's another company that has announced interest in another pathway to target pantazines. So you can see by understanding the pathways of pathogenesis in this disorder, it opens up an enormous array of targets that one can potentially imagine going after and treating. If you want to learn more about it, you can look at this review here. It describes the main drugs that I just mentioned to you earlier, and some others that may be coming in the future. All right, so I had only 15 minutes, and I gave you 3 examples in a very short period of time. Hope I didn't go too fast. If you're interested in this concept, please have a look at this review, which was sent earlier in a link in the chat. It describes the various options that we're potentially interested in treating in the near future. And it also describes some other trials that are going on and why we need to be ready for these trials, because we have lots of cool new things coming along, and we want to be ready and able to test them in a very rigorous manner so that we can determine quickly if they work and get them out to our patients as soon as possible. With that, I will close. This is my final slide, and I am going to stop the share then. So thank you all very much. Let's see. I think we have a minute or 2 for questions, if there are any. So let's see here. I guess since I'm chair, I'm supposed to be monitoring the questions too. So Kim sent the network list, and I have a question from Rick Staub, who has run Tyler's Hope for Dystonia for many, many years. And his question or comment is, at one point, there was an antibiotic, ampicillin, that was considered for dystonia patients, and some clinical trials were going to be run. I believe this came from UAB. Are there any updates on this trial? That's a great question, Rick. I don't have an update, but maybe Aparna does. I know Aparna's on the line, and if she has an update, maybe we can get her unmuted and she can comment.
So actually after the UAB study, we did conduct a small pilot study. Dr. Ramon Rodriguez was the PI for that study, and we were able to enroll maybe 4 or 5 subjects. But in that pilot study, the results were very inconclusive. The benefits, 2 of them benefited, but the other 2 did not. And that's why we decided to discontinue the trial. And it was specifically meant for DYT-TOR1A specific forms, specific severity. So it was even hard to recruit. So after running the study for 3 or 4 years, we wanted to get more evidence from other sources before deciding to continue.
Thanks for that update, Aparna. Do you think that the trial information you got was sufficient to conclude that it was helpful in 2 and not helpful in others? Do you need a larger number? Is there a subgroup that it might be helpful for, or is this something that still needs to be retested at some point?
I would choose the last option, and which is because I felt that the couple of people who responded, it was not a long-term follow-up. It could have been confounded by a placebo effect. So we definitely need more robust evidence in that direction before deciding to continue.
Great, thank you. All right, so there's another question here. Mark Hallett is asking about M4 specific muscarinic antagonists. So Mark's question relates to the fact that anticholinergics work for many different types of dystonia, regardless of the cause, genetic or idiopathic. But we don't tend to use them a lot, particularly in the older population, because the side effects of anticholinergics are not well tolerated. And so that has led several to suggest that a subtype selective muscarinic antagonist might be useful. The idea here is you can target the therapeutic effect and hopefully eliminate much of the side effect profile that's a problem. And aside from those brief announcements from some companies over the years that there's interest in this, I haven't seen any actual studies being done. If anybody who is on the call or on the panel knows of these studies, please go ahead and jump in and give an update. But I don't know of that, and I still think it's something, again, Mark, that we need to investigate because it's a great idea and it hasn't yet been tested. I'm not seeing any comments coming in on anyone who knows further about the M4 muscarinic antagonist, but I am seeing another question or comment. Marie Vidaye from Paris is saying there is also caffeine in ADCY5. So some of you may be familiar with this, a very, very rare, a combined form of dystonia, often mixed with other dyskinesias, chorea, tremor, etc. It's often pediatric onset. And there have been some very, very provocative studies suggesting that caffeine has a very big effect on this. And so I think good trials of that are probably needed before we decide that that's the way to go. I don't know of anything further on that. Marie, did you want to make a comment? So I am seeing, let's see. I'm seeing some things in the chat. So there is a review on muscarinics in the ACS Pharmacology and Translational Science in 2021. And it's called Discovery of the First, I must be missing a piece of it, muscarinic antagonist with in vivo anti-Parkinsonian and anti-dystonic efficacy. So yes, there is some development in this, Mark, and hopefully we'll see more very soon. And let's see. There is a question about whether or not procyclidine has greater potency at M4 compared to others. And the reason for that is there's some feeling that procyclidine might be better among the anticholinergics. I'm sure somebody knows the answer to that question. I do not know its subtype specificity though.